Well, first I want to advise you that I'm left-handed and that 9 out of 10 left-handed people are above average intelligence. And the reason I make this point is I know this because I'm number 10. Okay? So much for a little humor to start the day. I just wanted to run through these slides here. The tragedy of Dr. Semmelweis is that he was unaware that Oliver Wendell Holmes also, in the same year, 1846, had the same idea. So when I tell people the difference between Friedberg and Semmelweis is the internet, there you have it. I didn't know of Dr. Mulier or Dr. DeCock before this LinkedIn, and I've been using the LinkedIn platform very happily. And we all have the same idea about no opioids. The question is how to get there. I'm a great admirer of Dr. Mulier's work. I think that there's no argument with his results, his outcomes. My only argument is, as a previous speaker said, to keep it as simple as possible. Okay. I also admire the famous architect Mies van der Rohe, who said that less is more. So I evolved from an art to a science. I started off with hypnosis first and then dissociation, which was a qualitative technique. There was a lot of art involved, and I really didn't have any numerically reproducible concept. In 2004, I coined the phrase I stole from the surgeons, minimally invasive anesthesia for minimally invasive surgery. By this point, I'm using the biz with the EMG, the real-time EMG. And this is what the real-time EMG looks like. As you see here, these are the EMG spikes of the facial frontalis muscle, which is akin to the EKG of the cardiac muscle. There's no delay, and as the papers have said before, the spike in the EMG indicates incipient arousal. So, maybe we can agree that the BIS measures cortical function, whereas vital signs only reflect brainstem function. And my concept is that you can't have pain perception if you don't have input. And the NMDA receptor block, or saturation, occurs at the midbrain level. And I talked about this as a midbrain spinal anesthetic. So if you don't have any afferent traffic to the cortex, then you really can't have any cortical processing. So ketamine is known to be an NMDA receptor blocking. If you do not saturate the NMDA receptors with a 50 milligram ketamine dose before the skin incision, trocar puncture, or in my model, multiple local anesthetic injections, the brain really doesn't want to know this. And I say this because once you sedate a patient, the brain cannot differentiate between a mugger's knife and a surgeon's scalpel. All it knows is that the outer world of danger has now intruded on the protected world of self. And I tried my best to find something that would summarize the idea of OMG. It's like, oh my God, we've been invaded. Danger, danger. Sadly, they're still teaching that ketamine causes hallucinations, hypertension, and tachycardia, and the bonus is increased intracranial pressure. And this was all true when ketamine was introduced in the early days as a complete and total intravenous anesthetic. But it's not true if you create a stable level of propofol in the brain before you give the ketamine. So this is my magic formula. Propofol, ketamine, and tumescent anesthesia. And I published this in 1993. It was my first 50 cases. Of course, there was no IRB requirement in those days. And so as I embarked on this little experiment in 1992, I was really sailing off into the unknown. I knew that benzodiazepines blocked ketamine-induced hallucinations, but I had no idea if there was anything unique about the benzodiazepine molecule that propofol didn't share. But I did know that the first patient who woke up hallucinating would be the end of my little experiment. So I was titrating propofol to a loss of liver effects and a loss of verbal response, and then giving the 50 milligrams of IV ketamine. I began with a syringe and gradually switched over to a drip bag, 50 cc drip bag with a 60 drop set, which you have to admit is pretty qualitative. This is my concept of the technique. The propofol is the vodka in the martini, and the ketamine is the olive. Notice they're not mixed together. That is a different technique altogether, and one of the reasons I don't care for mixtures because you don't know which drug is affecting which thing. So my very first publication was the first 25 cases that said, indeed, hypnotic doses of propofol do block ketamine-induced hallucinations. Unfortunately, it was in the plastic surgery literature, and nobody in anesthesia reads it, and if they read it, they certainly would believe it. So the key thing here is dose and timing with ketamine. It's critical if you're going to have opioid-free, preemptive analgesia success. The dose is 50 milligrams, independent of body weight, and the timing is 2 to 5 minutes before stimulation. Very, very important, both things. So what happens in my model? Well, we do cosmetic cases. We do rhytidectomies, nose jobs, rhinoplasties, mammoplasties, abdominoplasties, liposuction, and we're dealing multiple anesthetic injections. And we know that all cosmetic cases can be performed under local anesthesia alone, but most patients really don't want to be there when it happens. So you have to figure out where in the spectrum, from completely conscious to general endotracheal anesthesia with neuromuscular blockers, can we satisfy the requirements of the surgeon and the patient while avoiding the small risk of balloon hyperthermia and perhaps PONV. So, the big stimulus for what most of you are doing is either the skin incision or the puncture of the trocar. The nexus between what you do and what I do is the skin. If you have to go through the skin, this is the critical function. In the old days, before we had cortical monitoring, we thought everything was great if there was no heart rate or blood pressure change with skin incision. Great, everything's fine. Well, that's good if your only interest is the brain stem. Okay? But that's not really the problem. So I was bold enough not only to coin a triad, but I started with a few postulates, and that is that the surgery type is really independent of the need for opioid-free anesthesia. As long as you're going through the skin, doing neurosurgery, cardiac, whatever surgery it is, if you have to violate the skin, the brain doesn't want to know that information. And so it's no less invasive than major cavitary or orthopedic surgery. So you say, well, with skin stimulation, there's no heart rate or blood pressure change. Did we really protect the patient brain from pain? Well, if that was true, why do we need analgesia after surgery? Why multimodal? Why ERS? Well, if you ask a patient who is on morphine PCA, are you still having pain? Invariably, the answer comes back, well, yes, but it doesn't bother me very much. So the second postulate is that opioids are not the solution. As Pogo said, we have met the enemy and he is us. Opioids are actually the problem. And since we're at an opioid-free meeting, I think that's not too radical a concept. So my first 50 cases between March of '92 and January of '93, there were 50 consecutive cases that I did that didn't need any analgesia post-operatively, and nobody was throwing up. And I said, gee, I found the answer. Fantastic. So my assumption was, pussycat, thank you. All right. My third postulate is if you don't saturate those NMDA receptors before you stimulate the patients are actually having pain during surgery. And I think we'd all agree that the cardinal function that we're there to prevent is pain during surgery. This was a devastating conclusion to my mind. The proof of the postulates is here in my textbook that came out 10 years ago, which is now in Portuguese and Chinese. And it summarizes, the experience, but over 20 years of biz EMG monitoring, we have numerical reproducibility. Propofol is titrated to a numerical number of 60 to 75. The baseline EMG, you notice there's two traces there. There's the biz trace and the EMG trace. And in all this experience, over 6,000 patients, not one hospitalization for PONV or post-op pain management. So it's not only for cosmetic surgery. Now, I throw in a quick warning because my patients are not intubated. They're breathing spontaneously. I now give a liter of oxygen so people don't say, you're not giving any oxygen. But really, the concept was room air spontaneous ventilation. We're in an office-based setting. We have no fallback position. We have no support. Okay, but what happens with the ketamine is that you will get a cough or sneeze and a complete closure of the vocal cords. So you don't hear the classic crowing. So the prodrome you must pay attention to is a cough or a sneeze. And then you must treat this promptly before the desaturation occurs. And I'm using a milligram per pound of IV lidocaine. But the propofol elevates the seizure threshold, so it's not really a problem. The problem is if you use a traditional technique of positive pressure ventilation, anterior jaw thrust, it's ineffective. And now your coronaries are starting to squeeze. So don't do that, reach for the lidocaine. I did 100 cases before I saw my first laryngospasm. I didn't know what it was until I put the mask on and tried to bag the patient. It's like trying to bag the wall, okay? And I didn't have any succinylcholine, which is a malignant hyperthermia trigger as well. So the advantages of how I put the patient to sleep is not to use a bolus. Use an incremental advantage, incremental induction of 50 micrograms per kilogram, repeated as fast as I can push the pump till the EMG starts to descend. So maybe we can agree all patients are not equal. There are no average patients. And I remind you of the story of the tortoise and the hare and who won the race. The clip I'm about to show you has 2 titles on YouTube. One is called Going Under with Goldilocks Anesthesia, and the other is called Propofol Induction with Biz Monitor Without Instrumenting the Airway. So every time you see my finger hit the pump, it's 50 micrograms of propofol, and the pump is also set for 25 micrograms per kilogram per minute basal infusion rate. You'll notice there's no change in the pulse ox sound, and you'll also notice nobody touches the patient. Okay, let's see if we can make this happen. Here is that the red area, EMG, will start to decrease before the yellow, the Biz monitor. And here's Dr. Lynn.
I didn't realize you're so tall.
Yeah.
Especially when I'm standing.
Come on, new person, right? Okay, because I'm going right now. I feel it.
Hopefully
relax.
it feels pleasant.
It feels pleasant. It's like my ideal way to die, but I mean.
Well, we tend not to do that.
And I'm like 106, you know?
Yeah.
I want my dog by my side though.
What kind do you have?
A Roddy. Well, I have my daughters too, but. So. Alright, here we go.
So this young lady is a nice young lady.
Will I be twitching?
No, no twitching.
I might be gassy because I didn't eat, but.
Yeah, that's okay. We don't charge extra for gassiness.
I'm feeling a little drunk.
But it's pleasant though, isn't it?
It's a drunk feeling.
Yeah. So
I might say, I'm sorry staff, but I might say shit that I don't.
You wouldn't say.
Just don't worry, you know, I haven't had food since 10, so.
Yes,
This is a
fortunately,
nice
this little
feeling.
video doesn't have audio in it. It's just the video, so
Please don't mind my dry mouth.
it's okay.
This is a nice feeling.
Isn't that nice? Now you know why everybody likes Dr. Friedberg.
And when I get home, can I eat?
Yes,
How immediate?
immediately.
Okay, so that makes some good porridge. If I wake up and marry an anesthesiologist, I can eat, right?
Yep, you can.
How many chances how many,
Put your arm right here.
I spent,
Okay. Make sure we get that.
I got
We're all
both.
set to go.
I got her and I got the Biz in frame.
Super. Perfect. That's great. You can stop now. So this is obviously for elective surgery, and this is a list of non-cosmetic cases that I've done, including sedation for the morbidly obese. With this approach, the U.S. military is using this technique, which earned me a U.S. Congressional Award. It's not just for cosmetic surgery. My friend who doesn't use a Biz monitor at the University of New Jersey, Glenn Atlas, is doing posterior craniotomies in the sitting position with propofol ketamine alone. Obviously, the patient is intubated and paralyzed and ventilated, so even though I depend on spontaneous ventilation, it doesn't exclude cases that you need paralysis and intubation. And I was asked to talk to the military in 2004, and they were kind enough to write a chapter for my book, which hopefully keeps you from pigeonholing my work in strictly cosmetic surgery, because we're all violating the skin. So you preempt the pain with the Nifty 50, you saturate, not merely block, 98 to 99% of the NMDA receptors at the midbrain, and that's what happens to pain. I used clonidine in the early years because I was desperately trying to mitigate the cost of propofol. The plastic surgeons, of course, loved the anesthesia, but they kept crying about the cost of the propofol. So after I collected data for 5 years and over 1,000 patients, pre-medicating with 0, 2, and 4 milligrams of midazolam, and sifting the data, of course, relying on brainstem signs, I couldn't find any change that was worthwhile to talk about. So I gave up midazolam pre-medication in 97 of June, and a few months later, Oxford published a level 1 study comparing 0 to 2 and said there's no difference. And I said, well, I guess this is okay. So I was using clonidine to help mitigate the cost, and I thought I was doing really well because you lower the sympathetic tone and therefore patients should have better results. So why do I call it the Nifty 50? Well, anything that rhymes is easy to remember, and the dose is ketamine, and the nifty part is dramatic outcome differences. Patients don't have the look of trauma. All of the drugs we give by body weight, but ketamine is unique among the drugs that we use. And why is that? Well, when I started doing this in 1992, I didn't know what an NMDA receptor is. I'm not really sure I could accurately describe one to you today. But the point that I had was if the patient was immobile when we did the injection of the local anesthetic, then we were good. But I noticed that it didn't matter whether the patient was 120 pounds or 250 pounds, they still lay still with the same 50 milligram dose of ketamine. I said, well, I'm not a scientist, but clearly this can't have anything to do with body weight. And the point is that the adult brain of a 250-pound man is not twice that of a 125-pound woman, okay? The midbrain is a very small portion of the adult brain. And the NMDA receptors are a small portion of a small portion. So that's why you get NMDA saturation with that dose, independent of body weight. And you get about 10 to 20 minutes worth of time for the surgeon to inject. You say, well, why aren't you giving ketamine after that? I said, because again, the brain doesn't really care much what happens once you're inside the body. Yes, there are other pain receptors inside the body, but nothing means as much to the brain as not knowing that the outside world of danger has just invaded us. And here's a slide that illustrates the difference in time. The other thing I think about is that using the Nifty 50 is like landing the paratroops without setting off the alarms. If you don't do this, basically everything else you're doing is closing the barn door after the horse is left. And so in my model, I rely on the absence of EMG spike with skin incision or local anesthetics. So even if you paralyze and intubate the patient, you will still see EMG activity. I only know this because I have friends who do cardiac anesthesia still. And I said, well, do you still see EMG when you paralyze? Yeah, we see it, okay. I'll also remind you that you don't need a brain to generate movement. And the classic problem giving sedation is when the patient moves and the surgeon gets upset and starts crying for more anesthesia, deeper, and the usual anesthesia response is, no, put some more local in. For the first 5 years I did this without the Biz monitor, I could never convince the surgeons why it was important to put more local in. They just wouldn't do it. And the other problem I have with TCI is you merely infer a brain effect based on your projected blood level. Nice if you don't have the ability to measure directly, but you do have the ability to measure directly. And with the EMG, you have a real-time signal. So you're not catching up to the patient, you're ahead of the patient. This was a quote I heard in freshman chemistry 50 years ago. It was William Thompson, who was knighted for his work in temperature. And he says, when you can measure what you're speaking about and express it in numbers, you know something about it. But when you can't express it in numbers, when you can't measure it, your knowledge is of a meager and unsatisfactory kind. It may be the beginning of knowledge, but you've scarcely in your thoughts advanced to the stage of science. So what he was talking about was temperature, what I'm talking about is level of consciousness. And so we really need to talk about the idea that it's the awareness of consciousness, not the reticular activating system down in the midbrain, wherever, that is the determinant here. So we're really interested in this effect here. And vital signs really reflect brainstem. So this is what real-time biz looks like. And unfortunately, the plug-in module does not allow you to demonstrate this information. This is freestanding. The old units, the A2000, was a monochrome. You could still do that. You had to go to the advanced screen setup. So with the biz in this configuration, you're now looking through the windshield rather than trying to drive your car with information that's part of the rearview mirror. These are the numbers that I look at, and I say moderate to deep sedation is somewhere around 60 to 78. General anesthetic is here, and overmedicated is here. And the thing that I'm concerned about when I see the levels of biz that we're running at the hospital here is that it's not the immediate post-op cognition that I'm concerned with, because you can't tell how well that patient can balance their checkbook or bid their bridge hand or relate to their friends. We don't know. And as I said in the earlier question, common sense is uncommon. Why would you want to run the biz below 45 when you know that general anesthesia is here and you know from my 20-year experience that there's no awareness or recall at this level as long as you keep the EMG to the baseline? Papers were printed that said, look, an EMG spike is incipient CNS arousal, and so all you need to do is increase the level of sedation. A simplified idea, because I'm not very smart, is that when red goes up, the white goes in. And you give increments to get the EMG back to baseline. And so right here, you see the red goes up. And we keep giving propofol in increments to get it back down. And so it allows you to surf the level of consciousness. As far as the subject of biz and ketamine, there are really no worries. I published this in 1999, that once you prepare the patient with a stable level of propofol, there's really no issue with a dissociative dose. And the EMG spikes, as I said, remain whether you have muscle relaxants or Botox. The other thing that makes this kind of fun is that it decreases the boredom because you really see the phenomenal range of propofol requirements to get to the same level of anesthesia. And part of the problem with our science when we talk about these patients and setting up studies is if you don't know that everybody's at the same level, how can you possibly compare what you're doing? Okay? And like I said before, 25 to 50 is the average. That's where the fat part of the bell curve is. But I've had as low as 2 and as high as 20 mics per kilogram per minute. So you have this one extreme. I don't know that there's any sound with this, and I'm not sure. I guess it's going to play, maybe. I just don't get what this is. You know, I put it on for you. There we go. I saw movement. Yep. Okay, so now we're going to look at there it is. She's 60 kilograms, 2 mics per kilo per minute, and this is just a quick shot about a half an hour into the case. I'm going to show you the vital signs here. Oh, we got some sound. Okay, pretty nice sound. So you're saying, how in the heck can this be? 2 mics per kilo per minute. That's homeopathy. I mean, that's not even weighing the syringe. And then this goes on for hours. Okay, I'm going to show you the next one. And this is like 2 or 3 hours later. So this case ran about 5.5 hours. And at the end, when we turned her off, she woke up and had no recall at all. And I said, if you don't have this to show people, nobody's going to believe this. I mean, I would guess, is there anybody in the audience who would really believe this without seeing this? And I'll remind you, there's no Photoshop for videos. Okay. Yeah. This is later in the case. And it's very, very hard when you see this to really believe it. And this is the second patient I had. The first patient was a 70-kilogram white female. Again, no remarkable thing except she said when last time they gave her propofol, she slept for a couple of days. Well, you can now imagine if this is like 10 times less than your low average, why she would have slept so much. So the case I just showed you, the summary is, she is an Asian, 325 minutes. She got 1 dose of ketamine at the very beginning, and the total propofol was this amount. And I say, wow. Yes, thank you, I do. The other extreme is the party girl, and you don't want to try drinking this 110-pound gal underneath the table. And you see everything in between. Like I say, most people are pretty much good at 25 to 50. And that's not a whole lot of propofol, and that's without the quantity. So having fun in the operating room is not something most people think about, but frankly, it's very boring most of the times. The classic definition of anesthesia is the person who's half awake, keeps the patient half asleep while he's being half murdered by the half-witted. Strangely enough, the surgeons only remember the first part of that. And of course, when people are over 50, we know that they're more sensitive. So who cares how sensitive they are if you go slowly and you measure them? The Lee study that came out in 2009 is very interesting because I was very upset when I found out that 1 patient a day dies in America simply of anesthesia overmedication. Okay? What I really missed the point going in is that 16 million of the 40 million a year who have anesthesia wake up with brain fog. And it's not really a mystery. So this is our best available technology to avoid routinely over-medicating patients. And this is what I said in the BJA, that until everybody is titrated to the same level, it's really hard to compare what you're doing with individual patients. This is a study that I published in 2000 that was a statistically significant 30% reduction. And I was also using clonidine as a pre-medication because, again, it was still proprietary. Propofol was very expensive. Even Emory University agreed. So by now we all sort of agree if you stop giving opioids, you don't have much of an issue with post-op nausea and vomiting. Although nobody dies, they may wish to die. If they were vomiting on the table, I can assure you in anesthesia we'd be very concerned, but it's somebody else's problem, we dump it on. Okay, so here's the picture of a classical abdominoplasty. We're going to imbricate the sheath, not the muscle, the sheath, and it's a completely different type of stimulus than putting a retractor in and holding those rectus muscles apart. And the clip I'm going to show you was done before the requirement for end-tidal CO2. With luck, it's not magic, it's not Photoshop, but it's a numerically reproducible paradigm. Do we have any sound? Yes? No?
This afternoon.
What you see there is the rectus sheath outlined in blue. Here are the pulse ox, pretty good tone. I'm going to show you the Biz monitor and the vital signs, and I'm going to show you what she looks like at the top. And the clip after that will be a clear HIPAA violation because you see her face.
Is that the HD one?
You see the spikes, and you see how we maintained a pretty steady level of hypnosis. There's her vital signs. This is room air. No airway. And then I'm going to pick up her jaw. I've gotten a lot better at this. And when you get better, the orbicularisaurus muscle. And then listen. That's what we call minimal trespass. Okay? Absolutely amazing. I've had many anesthesiologists come and watch me do this. They always ask the same question at the end. That was great, Dr. Friedberg, but what was the trick? What did you give the patient that you didn't show us? There's no trick. You cannot accept what you just seen. So a lot of times people say, I'll believe it when I see it, but actually the reality is they don't. Okay, Lily, what'd you think about the experience? Was it pretty good?
Yes.
Did you remember anything? You've been asleep for 4 hours.
No.
Don't remember a thing, no bad dreams.
No.
Wonderful. So that was really a good experience, then, huh?
Yes.
You like Dr. Lynn, don't you?
Yes.
He's the best. And Anais held your hand, and I held your other hand, and you had a good snooze.
Cool.
And no dreams.
No.
Fantastic. All right, well, speedy recovery. It's pretty amazing. Even I'm amazed when I see this because it's magic sometimes. For post-op analgesia, we put bupivacaine. We don't exceed more than 50 cc's, a 1/4% or a total of 125 milligrams. It's not necessary to inject it into the tissue. It binds quickly to the tissue. And if you need more for a mommy makeover with breast augmentation and tummy tuck, I dilute the 50 to 100, and okay. So hopefully in your operating room, it's not like this. And teaching the technique is simple, and teaching cooperation is not. I have used adjuvants and thought I was doing a great job, and when I stopped using them, I couldn't see any difference. So I have no problem if you want to use dexmedetomidine, you want to give magnesia, you want to do NSAIDs, but I just don't think it makes any difference. So the Triad is we can do it. This is my Opus publication. It's open. You can get this on the internet anytime. And basically, you want to not give the ketamine first. You don't want to bolus propofol. And you want to treat every patient movement, not with more drugs, but with more lidocaine if indicated. And make sure that you recognize the prodrome for Laryngospasm. I'm not sure what your tolerance is for sitar music, but I'm a child of the 60s, and I just wondering why, it's like how many anesthesiologists does it take to change a light bulb? Only one. The anesthesiologist really wants to have to change. I say thank you very much, and I'll take questions, or we can just